families or who've lost their battles against AIDS. And yet, thinking of them, I'm also reminded very much of their smiles, their laughter, their unique and strong and sometimes flamboyant personalities. And as beautiful as the quilts are, I think they only provide us a very quick snapshot, a glimpse into the lives of real people, into the depth of the goodness and the beauty of their selves and the souls of the individuals who have died because of AIDS. So today, I think we're all here to remember and honor all those individuals that I've known, many more individuals that you've known, and the many millions across the world who've lived with and died because of AIDS. And as part of that honoring, we need to not only remember them, but we need to continue their fight. Our fight, really, to get to zero. So in getting to zero, I think it's time for us to step back for a moment and take a look, a reflection of where are we at. First, if we look at the issue in terms of global progress, there's some things that we can celebrate. Across the world, 95 million people estimated have been tested for HIV, and the new HIV infections have decreased by 20%. And there's been a 24% decrease in infections among children. And at least in comparing 2011 to 2005, the number of AIDS-related deaths has decreased on an annual basis by 24%. And now, almost 10 million people are receiving treatment for HIV/AIDS. There's also progress within the United States. There's been more than 30 ART medications that have been developed in the United States, often with NIH funding. There's a range of effective HIV prevention strategies. The last time that I looked, the CDC had a booklet with over 30 effective prevention strategies, many of which were broken out for individuals of particular subgroups. And the federal government estimates in the United States over 300,000 new cases of HIV have been prevented. We also have the Affordable Care Act, which now, for the first time nationally, requires all health plans to cover HIV testing without any additional out-of-pocket costs. It eliminates the annual caps on benefits, which so often would cause financial ruin for people just trying to get the treatment that they would need. And it also prohibits discrimination, at least in insurance, against persons with HIV. So I think we can say that much has been accomplished, and yet much, much more remains to be done. So let's take a look at some of the major problems, again, first globally. Total prevalence of HIV across the world has been about 70 million people. Currently, we have about 4 million people who are living with HIV across the world. And there have been somewhere between 30 to 35 million AIDS-related deaths, including, in the last year, for which there's statistics, 1.7 million in 2011. There's 17 million children who are orphans because of AIDS. And while all that is going on, the U.S. has also just decreased their bilateral aid to other countries by $200 million, which has been 5%. And across the world, despite that figure that almost 10 million people are receiving treatment, the majority of people with HIV do not get treatment at all. There's an estimated resource gap between the need of what individuals require and what they receive of about $7 billion. Here in the United States, there's been over 600,000 AIDS-related deaths. There's over 1 million people now living with HIV, and less than half of those are receiving needed medical treatment. And even of those who are, of the total, there's only 25% who are both getting the needed medical care and have controlled viral loads. And despite that, there was $144 million cut from Ryan White in fiscal year 13. And current budget faces unknown and possible threats in the House for more and significant cuts to Ryan White. On top of that, we have some of the damage that's already occurred because of the sequester federal budget cuts. A recent survey of Ryan White providers nationally showed that many reported that those sequester cuts were creating significant disruption in patient care, including in primary care as well as support services. But unfortunately, there was less outreach. There were longer time that people had to wait to get an appointment, longer time in between appointments, less transportation assistance, and less case management assistance. So of course, getting to zero really has at least three major components: zero new infections, zero discrimination, and zero AIDS-related deaths. All three of those are vitally important, and they're all interrelated. But I wonder if the middle one, zero discrimination, isn't in some ways maybe the major driving force that's needed to accomplish the other two. This is especially true if we recognize that HIV/AIDS is not only a very complicated biological disease, but it's an epidemic that's driven by complex psychosocial, spiritual, and political processes and factors. So let's go back a moment and take a closer look at some of the data to help us understand this. Globally, 97% of people who are HIV positive live in low-income or moderate-income countries. Sub-Saharan Africa has almost 70% of the people in the world who have HIV are living in Sub-Saharan Africa, even though that region only represents 12% of the world's total population. And in that area of the world, there are 9 countries with adult prevalence rates of HIV of 10% or greater. And sadly, the AIDS is the #1 cause of death for women of reproductive years. And nearly 90% of the AIDS orphans, those 17 million, are children in Africa. Quick look at some of the factors related to epidemiology in the United States. There's disproportionate risk for certain groups, particularly for gay men and men having sex with men, for women of color. Black women have a 19 times higher rate of HIV infection than white women. But people with substance abuse disorders are much more likely to have HIV and then also to have problems with adherence and to have worse health and social outcomes. Again, people with mental illness who are 7 times more likely than a person in the general population to have HIV, and that they have greater problems with access to care, to adherence, and suffer worse outcomes. And also, that so many of the individuals who are living with HIV are people who've been abused and traumatized. Those last two groups, individuals with the abuse and trauma and individuals with mental illness, often are neglected and overlooked. There's nary a mention of mental health and mental illness in the national HIV/AIDS strategy, even though, again, individuals are at 7 times greater risk and have worse outcomes. As far as I could see, the issue of abuse and trauma was not even really focused upon. Because those are important and overlooked and vulnerable groups, I'd like to pay a little bit more attention to their special needs and challenges. There's some factors related to people with mental illness that makes their care for HIV and AIDS even more challenging. not because people want it to be that way, but really just as a matter of part of their health condition, mental health condition. And I'm generalizing, this does not apply, of course, to everyone, but across the group, individuals often have less insight and judgment about their illness. They may have a lower sense of hope and morale and motivation. They have fewer coping and functioning skills, including their ability to be able to access resource and treatment. And there can often be a suspicion of providers, a lower level of trust, which sometimes is illness related and sometimes really related to, again, those histories of abuse and trauma, even sometimes for some people of feeling negative experiences with service providers. There's greater poverty and people are living with fewer resources, and they're more likely to have those co-occurring conditions of substance abuse as well as trauma. There's also service system problems for people with mental health disorder. There's few specialized services, and the service system itself tends to be fragmented. So stepping back for a moment, let's summarize again a little bit about what we know about the people who are most likely to receive or to have HIV/AIDS across the globe as well as in the United States. These are people who are poor, people who are in some way have been stigmatized or devalued or discriminated against, whether that's because of race or sexual orientation or mental health status. You know, there's the discrimination, unfortunately, that occurs against people sometimes with HIV, the phobia that some people have about catching HIV or AIDS from utensils or from shared living conditions, and that's troubling and that's unaccepting. But I also think at an even more fundamental level, there's a meta-level discrimination against poor and marginalized people who are the people who are at risk of HIV and certainly at risk of not getting adequate treatment and services. You know, in the past week or so, I've been struck by the number of 30-something million, which I've come across that number for a couple different things, including in unrelated projects. And 30-something million includes the number of those who died because of AIDS, the number of people currently living with HIV, and it also is the number that represents the number of millionaires in the world. You know, I certainly, clearly, do not wish HIV/AIDS on any person, including those 32 million millionaires in the world, the 1% or less, who own 41% of the wealth in the world. But I can't help wondering sometimes, what if the epidemiology of HIV and AIDS was somehow different? If it was related to things like living in big mansions and having private jets and yachts and having a lot of money and material possessions. And if the disproportionate group at risk then was not the poor and the vulnerable and the marginalized, but the wealthiest 1%. Would we still have the same problems with HIV/AIDS? Would we still have a situation where less than half of the people get the treatment that they need? What do you think? I don't think so either. My point is not to promote any kind of class warfare, and any talk of progress in HIV/AIDS also really needs to recognize the outstanding work of the Bill and Melinda Gates Foundation, who have given over $2 billion and helped make a significant difference in that progress across the globe. Instead, my point is really, we need to see beyond class. We need to see we are one family, a family rich in diversity, with Africans and African Americans and Asians and gays and lesbians and transgender and straight and white folks, but we're really all one people. And we need to recognize we have somehow misplaced our priorities in this global economy, focusing on the wealth for the wealthiest instead of the health and the well-being for all. Our lives need to be about a deeper purpose than acquiring M&Ms, money and material possessions. At a fundamental level, we need values that value life and well-being over money and material wealth. Where do we go from here? There's no single strategy that will get us to zero. We need a patchwork quilt of efforts. And those efforts really begin with our consciousness and our compassion, our heart and our soul. We need to ask ourselves, who are we and why are we here? What really matters? What's important? We need to find a deeper purpose. For example, about serving and healing and making a difference for human life, health, and well-being. We need to put those intentions and values into action and into advocacy. And we need additional resources. So here's a brief passage from the National HIV Strategy for the United States I'd like to read to you. It says, there are constraints on the magnitude of any potential new investments in the federal budget. The strategy should be used to refocus our existing efforts and deliver better results within current funding levels, as well as highlight the need for additional investments. The key steps, the plan continues, are to increase the coordination of HIV programs and develop improved mechanisms to monitor and report on progress toward achieving gains. So basically, the federal message here is you're not getting any more resources. You need to coordinate better, you need to be more efficient, and by the way, we're going to develop some mechanisms to be able to track to see how well you're doing. That's a rather familiar message in this resource-stingy era that we're living in. And yes, it is important to coordinate, to be as efficient as possible, to track our progress, to know how we're doing. But it's not very convincing to me that those things alone are going to help us get to zero. Not when part of the problem is the pattern of discrimination we're looking at during this time when there's growing wealth in the United States and across the globe, and how that disparity gap between rich and poor is getting bigger and bigger. Not when less than 1% owns $99 trillion, and meanwhile 2.4 billion people live on $2 a day or less. It's even more incredulous when we look at how our governments have been spending their money and wealth. If you remember, the estimated resource gap worldwide that's needed for treatment for HIV/AIDS is about $7 billion. And we can compare that during the financial recession of 2007 to 2010, where world governments worldwide spent $7 trillion to help financial markets. In the United States, the government, to one company alone, Goldman Sachs, provided $6 billion. That company, by the way, turned around and gave $2.4 billion to their executives in bonuses. So, since this recession, those with the financial sectors and the wealthiest are getting richer, even as most people are slipping, and the gap is widening with the poor. So we need to be clear. We need more resources for people HIV positive and with AIDS. We need to keep doing more of what's working. We need more research, basic research that will provide us more effective treatments, that will someday hopefully provide a vaccination against HIV, and more prevention strategies. And despite a difficult web startup to the Affordable Care Act, it's going to do many good things, we hope, but we need Ryan White, and we need to keep Ryan White strong. It cannot be replaced. Medicaid to those people who are willing to work in Over 20% of people served by Ryan White programs are in that 101 to 200% of the poverty range. And we need to provide more services to those who are the most vulnerable and at risk. People like the individuals who are homeless or with mental illness or substance abuse or for whatever reasons need more intensive service for access, for treatment, for adherence, for living well. And that includes we need outreach and specialized services, easy for me to say, on their own terms and turf, with flexibility, with emphasis on building trust and caring relationships, and really with assisting people with those immediate needs that they have, as well as providing the needed long-term treatment and support. We need to target specialized services to those folks who are most vulnerable, and we can know that those services do make a difference. I wanted to just very briefly here highlight some findings from a project that we did in St. Louis with a federal grant over a 5-year project serving largely minority persons with mental health disorders and with HIV, many of whom also had co-occurring substance abuse disorders. We outreached over 400 people across the project and provide services in a number of different categories, as you can see here, including therapy to almost 350 people, medication management to 286 individuals, and intensive assertive community treatment to a smaller number of folks. All of that based on the individual person's own needs and conditions and preferences. And what we found is that those services, let me back up a second. 81% of the people that we served were African American. 3/4 were males. And we found that by 6 months of service, people were realizing significant positive gains. Substance abuse declined significantly. Depression went down also significantly. And other mental health symptoms, including the psychotic symptoms as well as anxiety symptoms, also decreased significantly by 6 months. We also saw that over time that people improved in their overall health. The CD4 counts went up, particularly by discharge. And the percentage of people who had detectable viral loads or undetectable viral loads also increased significantly. And we had a small but still significant positive finding for people becoming better housing, less likely to be homeless or less likely to be in precarious housing situations. So we know if we provide the right services that they can make a difference for people, even those who are most vulnerable, those with mental illness and substance abuse disorders. What you do makes a difference, and there's still so much to do. Here today, too, I think we need to celebrate the work of so many individuals, so people like Sheila Jackson and Tanya Brown and Don Gerard and many other individuals who worked so hard for years and even for decades. I'd say they worked tirelessly, but I think the truth is the work is often tiring. And that's testimony to their courage and dedication and all of yours to continue to do that work. So we need to renew ourselves and we need to keep going. And all of us need to be part of something bigger. Our efforts part of something like a large living patchwork quilt, so that someday there'll need be no more AIDS memorial quilts. Thank you.